We are now recording. Dr. Charlo is a developmental psychologist who's been working with individuals with intellectual disabilities and developmental disabilities for over 30 years. She's worked with people with severe co-occurring psychiatric disorders and challenging behaviors. She's an assistant professor of psychiatry at the UMass Medical School. She's published original research. She's lectured widely on a variety of topics related to the care of individuals with IDD and autism spectrum disorders across the United States, Canada, and in Europe. Dr. Charlo was a co-principal investigator with Dr. McElvain.
Yeah.
McElvain, thank you. The director of the E.K. Shriver Center on an NIH-funded grant studying depression in children with ID, and she was the principal investigator for a UMass Medical School Internal Initiatives grant. She was the lead author on the NADD-sponsored DMID2, the chapter on depressive disorders, and she also wrote the section on psychiatric disorders in the autism spectrum chapter. Dr. Charlo and Shriver colleagues published research regarding medical comorbidities among psychiatric inpatients with ID. Dr. Charlo's designed and directed multiple acute inpatient and outpatient psychiatric services for individuals with ID and ASD, providing oversight in program development, operations, and providing extensive training to personnel within these varied programs. Dr. Charlo is the director of the Beckett IDD Mental Health Multidisciplinary Evaluation Team. We are, again, very thankful for her willingness to present today on the complex needs of individuals with IDD and dual mental health and medical diagnoses. So I'm going to pass the baton to Dr. Charlo.
Thank you. Thank you so much for having me. I get really happy and excited and pleased when people want to learn about this particular topic because it's so near and dear to my heart. And those of you who know me know that I like to think of myself as a little bit humorous. And a lot of the work that I've done over the years, you know, it's like you're going to laugh or you're going to cry. So once in a while, we have to smile. One of the interesting stories that I'm starting with is where this title came from, Why Risperdal Won't Help Your Toothache. I worked with a very beloved colleague of mine who actually is the person who initiated a program called START. I don't know how many of you know about START, but we had an individual who was on the inpatient unit that I used to run at UMass. And this person had terrible epilepsy and lots of extreme emotional challenges and behavioral challenges. And she was on our unit and we helped her out and she did really well. We actually took away some of the excess medication she was on, developed some other interventions. But the long story short, when she went home, she had a relapse of agitation and was hitting herself in the jaw a great deal. And her staff panicked and thought, oh my God, she needs her Risperdal back. But in the end, we discovered, or Dr. Beasley actually discovered, that she had an impacted wisdom tooth. So we decided that Risperdal wouldn't have helped her toothache. And in fact, getting good dental care did. And she ended up doing very, very well. But that's kind of a key element to some of the stories, some of the stuff I'm going to talk about. So I also, like, just to kind of make this more interesting, I used references to a book I don't know, many of you may have heard of, and it has some really great quotes in it, and it's called The House of God, and it was written many, many years ago, and it's about a guy who was a resident in a big teaching hospital in Boston. And he talks about what it was like to be in his residency and worry about taking care of people. At that point, it was taking care of people who were older and who it was really important to keep them alive. We didn't have those so many of the living will things at the time, and there were people who really had ceased to be who they used to be. They were maybe brain dead. They weren't alive anymore in the way that they used to be, but they didn't have those things where you would let people go peacefully. In any case, he wrote some things, again, combining some stark reality stuff with some humor. And then he recently did sort of an updated thing and said some really poignant stuff. How can we care for our patients if nobody cares for us? So I think it's really important to think about workplaces and how they have cultures. And some of what I hope I can teach people about is something that I've used many times over and over again in the programs that I've developed to create a culture where we're taking care of folks or helping folks or supporting, providing services to people with IDD. And that the culture may be as important as all the facts that we learn about how to help take care of people. So I like to quote this particular gentleman, and he had what he called the laws of the house of God, and he just added some new ones that were kind of interesting to me. And he mentions that isolation is deadly, and if you're not connected, you can't really talk about anything. And I think that's a lot of the culture that I've always worked really hard to create in the programs that I was involved in. And I think it's a really important thing. So part of what's important in why I run a multidisciplinary team service is how we look at diagnosing people. So this was a cool quote from a guy who's a neurologist and a medical internist. And he talked about the fact that effectively directing treatment requires correctly sort of identifying the source of dysfunction. So a lot of the work that I do too is also really trying to focus on a whole person kind of differential diagnostic assessment. So somebody comes to us and they've got lots of struggles and troubles and challenging behaviors and emotional dysregulation and all this kind of thing. And our chore then is to really, really find out what are all the things that play a role in this person's distress, their struggle, their difficulties. And then we develop treatment from that understanding. So people with IDD, I'm sure many of you are aware, have very high rates of medical problems. And they also have high rates of unmet medical needs. These are some a little bit older studies from Europe that looked at this, but they were interesting because they actually had people even in some medical care, and they had nurses go out and do evaluations of them. And often people had undetected or unresolved medical issues. And this was some important findings at the time, but there's been recent findings showing similar patterns. So why do medical problems get missed? I had a professor in the Eunice County Shriver Center when we were working on research together. How come if these people have a primary care doctor, how come they miss their medical problems? What's the matter with the primary care doctors? But I think it's similar to the problems we see when we want to understand how somebody feels. And they have an intellectual disability, and they maybe have some difficulties with communicating their internal state, talking about how they feel. Sometimes that's a real struggle to help somebody and support somebody around that. We often rely a lot on informants. And I think around the whole medical issue thing, I've come to learn that people with IDD are pretty bad at reporting their own medical problems often. It doesn't mean we don't ask, and it doesn't mean they can't sometimes be quite accurate about their own medical problems, but often they aren't. And I think that's when things get missed. And informants, like if you're one of the caregivers in group residence and you're taking care of somebody, it's hard to be the person who has to report what somebody else's health issues are. And informants will often, I've been surprised how often they'll say that somebody, they know that somebody's just doing something for attention, that my physician team members would eventually find out there was an actual true medical problem. And so we want to be careful about assuming we understand those things. So I think it's really important to distinguish between causes, from different kinds of effects. So like many times we need to be skeptical of the diagnoses that people show up with. I'm not saying that they're never correct or we're always skeptical, but if somebody's they're not doing well with their treatment, I get a little more skeptical. And when there are symptoms or challenging behaviors that we're really focused on, I want to make sure we understand who's being affected, why somebody's distressed, why somebody seem unwell. And then a big question I always ask is why now? So I've had to think a lot about what does it mean to rule out medical problems. I just had a case recently, and I was trying to explain to one of the trainees that, be careful when you write into your plan that we will first rule out medical problems, because it's not always that simple to, quote, rule out the medical problems. Everybody thinks, well, the psychiatric one's much more complicated to figure out what's going on. The medical ones, we know, you either have the medical problem or you don't. Well, surprise, surprise, that's not true either in many, many instances of many different types of medical issues. Sometimes we would say, however, the first person when you have an uptick in your challenging behaviors that you see clinically might not need to be a psychiatrist, even though what you're doing is screaming and having meltdowns and hitting people. You maybe first need to see a different kind of doctor. And that's part of what I hope I can, get around to teaching here today, to giving people, have some tips about this, how to pick up on these things. So telling someone you feel poorly without words. So one of the things that, I talk a lot about when training caregivers about how to pick up on these things, I'll get the story that somebody has a high tolerance for pain, and it may be true, it is true in some people, and one's tolerance for pain varies from person to person. But sometimes the real difference is how I demonstrate it, not really that I have a different tolerance for it. So just because I scream and I hit somebody, or I say I have to go to the hospital or something like that, rather than saying, truly, my stomach has been killing me all week, and I don't tell you that, or my sleep is just a mess. It looks like I'm sleeping, but I wake up and feel tired. Whatever that story is, we don't always get it. We don't always, what we really might just see is this manifestation of distress in the form of challenging behaviors. And I assume I'm preaching to the choir. Everybody says, yes, we'll check for these first. And then case after case after case would come into my inpatient unit and gets referred to my team. And people said, oh, yes, we looked for the medical things first. And lo and behold, there's all sorts of medical things, and we didn't find them. So this is how I've gotten to be concerned to try to publish and teach and write and talk about this. So presenting problem to the doctor. Here's two descriptions of the same person that you might present to a physician. So there's 25-year-old female feeling anxious and she can't breathe and she has a history of panic attacks, versus 25-year-old female, short of breath, tightness in her chest, 2 weeks postpartum. So it's kind of interesting. I stole these from somewhere. And the point is that how I describe the case influences the assessment of the case, or how I describe the person's distress and symptoms and difficulties affects, how the clinician doing the evaluation, the physician will interpret it. We have a lot of power in this, even if we're not the physician examining somebody for medical issues. I found this study was kind of fascinating. So they did this investigation of patients with aggressive behavior who were being presented in the ED, and this had nothing to do with, people with IDD specifically, just anybody with or without ID going to the ED. 24% had medical issues contributing to their aggression, and these weren't, a full workup really wasn't done in a standard manner. And they concluded, not shockingly, aggression is not a diagnosis. But guess what? For people with IDD, whether anybody says it is or not, it gets treated like it is. That's how people get treated. They get treated like, what I needed to know is that you've been very, very aggressive, and that tells me I know you need Risperdal. Maybe I shouldn't jump to you're irritable and aggressive, so that means you need Risperdal. Maybe what I need to do is think about what are all the different things in you, your life, and your surrounds, and what might be contributing to the fact that you're showing this aggression now. And there are often, again, preaching to the choir, multiple potential influences. So thinking about reasons that medical diagnostic errors or omissions may occur, disruptive behaviors displayed by patients do seem to induce physicians to make diagnostic errors. We actually have a research study that talks about this. And I personally had the experience of, with my physician teams, of noting that being bitten during, I think somebody just joined who's walking around, has their camera and has their sound on, if you can, I don't know. Fix that, thanks. Being bitten during the physical exam actually does impact the doctor's clarity of thought during the case. And I say that kind of tongue in cheek, but we used to do a lot of, these kinds of assessments I can picture my poor physician colleague, Dr. Baldor, getting really attacked during a physical exam. And most of the time he didn't, because we worked really hard to avoid that. But it definitely is an interesting thing, having once done like training for the family medicine department at UMass. And a lot of these folks, the physicians, they were talking about how difficult it was to get regular general medical evaluation done of their patients who had intellectual disabilities or autism spectrum disorder, who would come and be really disruptive in the waiting room and even, violent in the waiting room. And so we did a whole training for them about, how to get through these situations where we need a good medical exam. And definitely the occurrence of the disruptive and aggressive behaviors has a huge impact on whether you get a good medical assessment. And if you don't get a good medical assessment, it's a problem. So way back for years, there have been studies, those of you who are, ABA folks or BCBAs or whatever, way back in our history of development of behavioral treatment, is study that looked at how physical illness can be directly linked to problem behaviors or challenging behaviors in people with IDD. So we find, all sorts of studies about things like menses and disruptive behaviors and other kinds of problem issues physically being directly associated with aggression and self-injurious behavior and other kinds of things. And the interesting thing to me too is that most people with IDD who are referred for psychiatric care due to problem behaviors, aggression, SIB, and disruptive behaviors, a lot of them have comorbid medical issues, as I mentioned. But when you get referred, if you have IDD or autism spectrum disorder, when you're referred for a psychiatric evaluation, it's usually because you're disruptive in some way. It's not always, but a lot of it is. A little bit more than I think in the population of people without IDD. Aggression is more often a challenging problem that brings people to psychiatric attention. So James was a 28-year-old guy with moderate ID and autism spectrum disorder with a history of these outbursts, or I call them meltdowns, where he would get aggressive and hit and kick and spat, and he had some banging his head, and big thing he did was throw himself on the floor. And doing well. Then, after we had him on our unit for a while, we made some adjustments to his treatment in various ways, and he looked pretty good. But then he started flopping himself on the floor again. And we're trying to like, this doesn't make any sense. Everything else is starting to look better. And then it turned out this behavior, was actually a reflection of orthostasis. So orthostasis is a condition in which to simplify it, when I go from sitting to standing or lying down to sitting to standing, my blood pressure will suddenly drop and I feel dizzy. So what he was doing at that point, he had a medicine that was causing this, and we changed it and it all got better. But what he was doing is putting himself on the floor because he felt dizzy. So very different reason than putting yourself on the floor because you're having an outburst and you're just unhappy about what's going on around you. Ned was a 17-year-old guy with autism spectrum disorder and limited speech. He had a lot of words, but limited, I should say, limited functional communication skills. And he had been very agitated. He's a big guy. And he wasn't cooperating with activities. They tried everything. He was on all sorts of different behavioral treatment interventions were tried. He had multiple high doses of antipsychotic drugs. He had 2-to-1 staffing. All this stuff went on. When my evaluation team looked at his history carefully, there were clues that GI issues might be a problem. And it turned out actually that we finally took a while to get him a good GI workup, again, because he got so aggressive. But the evaluation by a gastroenterologist that he finally had reflected that he had some really bad esophageal erosion, like painful looking esophageal erosion. And he didn't complain. He didn't say, oh, like I have this like terrible feeling in here and it's awful. I remember my brother had reflux and he thought he was dying. So in any case, treating the medical problem that he did have just incredibly helped his agitated behaviors and his outbursts. And his mother was like thrilled. And of course, my case examples, I like them to be the ones where we were very helpful. And he did very well after that. So as Brooke mentioned, part of my history at UMass, I ran a 10-bed locked inpatient psychiatric service. I always show this picture and say that's my nurses who are on the cutting edge in their field. In any case, we had 10 beds, age 16 and up. About 60% were males. I don't know if people notice this, but for people referred to a service, like a specialty service like that, you often see fewer people are referred who have mild intellectual disabilities, as you would find if you just did a population survey in the area from which the referrals emanated. So we tend to see proportionately more people with moderate and severe ID in these situations. But all the patients had to have intellectual or developmental disability and be in the DD service system somehow, and all had to have acute psychiatric issues to meet level of care requirements to come into the hospital. And that unit was there at UMass for not quite 10 years, and I helped develop it and ran it for 8.5 years. And it's out of that program that I developed the outpatient multidisciplinary evaluation service. That's now run by Beckett. It used to be run at UMass, but I run it through this smaller agency, Beckett, now. So the medications of the patients were tons. I'd love to talk to all of you, but we find a lot of the folks that we're seeing who aren't doing great. The ones who came to the unit weren't doing great. They weren't at their height of happiness and wellness. And they were on a lot of psychotropic medications. In this case, an average of psychotropic medications of very, very high per person. And then there were people who were on 5 or more, like a fifth of the population that we saw. And that's older data. It's even worse now from recent population studies that I've seen. And we did this study where we were really looking at, what goes on with the relationship between, your medical issues and your needing a psychiatric inpatient stay. And we found that inpatients with more medical diagnoses actually had statistically significantly longer stays on the psych unit. They weren't in the hospital for a medical problem, but the medical problems we found seemed to be correlated with needing to be in our unit for the psych unit for a longer period of time. And the more psychoactive medications they were taking, the more medical problems they had. Go figure. Well, didn't surprise me. But using very strict criteria, 41% of the cases we were able to conclude were almost certainly only on an locked inpatient psychiatric unit because there were missed medical issues. These medical issues could have been caught and treated, and this person might not have needed an acute psychiatric admission. And for many people, it's not, I should say, not the only problem, but even if it's causing a percentage of the stress and distress, we want to go at it and get hold of it and treat it and make sure the person feels better. And there may be multiple things at a time, but there were some cases who were truly almost only on our unit because their medical issues or medication side effects were missed. Excuse me. So frequently, it's reported that specific medical issues are suspected to be, like, as I mentioned, we'd hear it all the time, fake for attention. If I had Dr. Baldor, who I've worked with for many years, who's a fabulous primary care family medicine fellow. He's in charge of a family medicine department at one of the UMass facilities now. But, he would really get upset about how often patients were brought to him and people would say, oh, he's just doing that for attention. And he would find these like real medical issues and feel concerned, that people didn't pay enough attention to those. So, so you're thinking, what if you have persistent stomach pain and your family has to speak on your behalf to the primary care and tells the doctor, oh, it's nothing, he's just faking. It really worries me, that unfortunately, even with the best of intentions, when we're speaking for somebody else, we have to really be cautious about those kinds of things. Can I really tell if he's got a stomach ache? Maybe he doesn't know how to tell me that. Maybe the only thing I'm going to see is agitated behavior. So here's some easy things that I've found with my teammates over time that are, we used to call them a low-hanging fruit. There's things that you can treat and you can improve somebody's overall well-being, and yes, they may still have some psychiatric and challenging behavioral issues, but we want to get at these things and make sure we don't miss them. So constipation is a very big one. I'll talk a little bit more as we go along about that. Acid reflux, I gave you that case example of this gentleman. There was another case example of a guy who ended up in an induced coma because he was so self-injurious until they discovered that he had horrifying acid reflux. So these things happen. Even if they don't happen a lot, they happen, and there's something you can help. You can do something about it. Sedation. Sorry, get rid of some of these. Sedation, muscle stiffness from the drugs, EPS, extrapyramidal symptoms, urinary retention, orthostasis I mentioned. Dehydration gets missed all the time. Urinary tract infections, dental issues. As I said, Risperdal won't help your toothache, and missed cases of encephalopathy or delirium-like states. So sometimes people get what I would call a kind of brain fog from their medication where they're in and out of making sense. And that gets mistaken as psychosis. So I put this together, and Dr. Belda thought it was pretty hilarious and used it in some of his trainings. It's the what I call the constipation true-false quiz. And if I was with you, we'd go around the room and do it. But in any case, if constipation is suspected and we send a person with IDD to see their primary care physician and she says he's fine, we no longer have to worry about it. False. If the person with IDD only complains about stomach aches when he isn't getting any attention, it's probably a behavior. False. When an x-ray is taken of the person's abdomen and the radiology report says it's negative, we don't have to worry. This one's trickier. That's also false. We actually have to ask the radiologist, would you tell us if there's, please do a comment on stool content, because the radiologist may think, oh, they just want to know if the person has a full-on obstruction, something they could die from. They don't usually do these x-rays because a person doesn't know if they're constipated or not. That doesn't happen for most of their patients. So we have to ask them. If the person is given a stool softener like Colace, then they won't get constipated. You don't have to worry. False. If the person is taking bowel medications like Metamucil, no worries. Yeah, this one's trickier, but it can be for some people. You have to drink enough fluids to make it work, or else it actually aggravates the constipation. I kind of could go on about constipation for a long time because it's been such a critical factor influencing people's distress. And I sadly recently really have had two cases. One person died that we saw on the evaluation team we had seen a year ago from a bowel complication because people didn't follow up on the constipation issue. It wasn't from Connecticut. I won't even tell you where. And then another case I was referred recently where a guy who's like 22 has had to have had a bowel perforation and now has a colostomy. And in both cases, there was huge polypharmacy that contributed to their constipation problem. We'll talk a little bit more about that. So cases of new or worsening incontinence, I always ask, please, can you guys find out from the doctor, or if it's my team, my doctors will suggest that people check for urinary retention if the individual, it could be if the individual's on medicines that can cause that, or it could be that the person, and we may not even know it just by looking. We'd have to find out. Some people have what we call neuromotor challenges. They have a brain that's not functioning completely as usual or typically. And so they may have low tone, hypotonia, and they may have that from birth. And that can actually be something that affects, how your bladder works. So you have muscles all through your body and through your system. And so you can have a thing called a neurogenic bladder. And this can happen more often in people with IDD. And then things can also be aggravated in terms of urinary retention from medications, especially cogentin. So a sad story for me is finding a non-psychotic person with ID on antipsychotic drugs that don't really help their challenging behaviors very much. And then they have to be on cogentin or benztropine for the side effects from the ineffective antipsychotic drug. And then they get constipated. It causes them to be irritable. So they get on a mood stabilizer to join the antipsychotic drug. I could go on. All of these drugs listed here have some potential. So if you both have a little bit of hypotonia and you're on some of these medicines, and perhaps you're a person with ID who doesn't love being physically active, you don't eat well, all these things contribute. And again, these things all mostly cause us to not feel well. And when we don't feel well, we may be one of those people who display our distress and unhappiness in challenging behaviors or moodiness, etc. So it really can be something that affects people all around. So early warning signs for dehydration. So I had a particular case where this fellow had a definite, he was in a respite, or urgent respite stay place where I was working, and he had a history of really severe depression. And the staff were telling me that he's getting depressed. It's, you know, we thought he was doing so well, and here he is, he's looking like really depressed. And I did some observations, and he had really dry lips, and he looked really tired. And lo and behold, his blood pressure was a little bit low. And turns out, like, he was borderline dehydrated. He wasn't flopping on the floor dehydrated, but he was borderline dehydrated. And so we got him to be he didn't want to drink. He didn't like drinking water. So I bought him a water cup with something on it that he loved. He loved some kind of superheroes. Even though he was an adult, he sort of like some of those things. Excuse me. Then drugs associated with that thing of orthostasis that I talked about, where people, a lot of times people will have gotten a blood pressure taken, but not so often orthostatic checks. And those are, if you're going to check for orthostasis, you have to have the person sit, take their blood pressure and pulse, have them stand, take their blood pressure and pulse, and ideally they lie down, then they sit, and then they stand. And when we do our multidisciplinary evaluations in person, the primary care physician, now it's Deb Dreyfus, and she's wonderful. She might be doing that as part of the exam. As long as we can get some cooperation with that, we try to get that done and check if we have any worries that the person has been falling down or looking tipsy or acting like they might be dizzy from observation or self-report. I mean, there are people who I worked with who complained about being dizzy, and people just kind of blew it off. It didn't take it seriously. So drugs that have hypotensive side effects, nitrates. So sorry to say, those are erectile dysfunction medications. Not a lot of our folks are taking them. Drugs for Parkinson's disease, antipsychotics, anti-anxiety agents, a lot of different medicines can cause orthostasis. So many of them, it's more like we got to look for those signs. So delirium or acute encephalopathy. So I worked with a movement disorder specialist neurologist for a number of years who worked on the unit, and I used to do rounds with her every day, and I learned a lot from her. So we had a number of cases, not a huge number, but a number of cases who had what she called metabolic encephalopathy from medicine, such as Depakote, where they would be in a bit of a brain fog. So they'd have an altered mental status and generalized kind of dysfunction neurologically that was reversible. So the Depakote went away, and this guy's clearing happened. His thinking cleared up. And I remember being so impressed, but it took many months for even after the Depakote was stopped for him to look like his old self again. But I knew he was his old self again because he always asked me for a date And when he was in the delirium kind of encephalopathy state, he wasn't interested in me anymore. It was very disappointing. And then Dr. Ravin called me down to her clinic and said, "You've got to see X." And I walked in and he was all smiles, and he asked me out again. So I knew he was better. He was back to his old self. But we don't want to jump to a dementia diagnosis. A lot of it looks similar. It looks like dementia a little bit when there are these mental status changes, because sometimes it's reversible. It's something we can find. Dementia is kind of the thing at the end of the road, and we're not going to be able to make it go away in most cases. So we really want to think, what else can this be? And could it be something like a problem with the medicine? So does the patient need Depakote for her mood regulation? I remember this one patient, it really hit me. The light bulb went on. I said, so, why does she take Depakote? She's here to see us because she's just having a horrible time. She's so moody and miserable and mostly unhappy and whatever was going on. And they said, oh, she takes the Depakote for mood regulation. I said, yeah, but she's like got the most dysregulated mood of almost anybody I've ever met. So why is she taking Depakote? It's for the mood regulation. So it's that whole thing about if you look it up on the internet, that might be listed there, that's something you use it for. However, I don't think you keep using it for that when it doesn't work. So other kind of problems you can get: dehydration, headaches, constipation, dizziness, orthostasis, complicated sleep architecture problems, dental problems, and acid reflux. All these things can happen. We really don't want to take medicines with all these side effects unless they work. I think it's good if they work. And believe me, over the years, people on my team and on my psych unit, we used plenty of medicine, but we had this bias about trying to be sure it's something that worked. And again, this problem in the United States right now, people with autism and IDD are just very, very medicated if they have any challenging behaviors or mood issues. So forced vomiting. Most any of these medical concerns that may be viewed as done intentionally when the source isn't very clear. I had an RN tell me once, not that long ago, that she could look at this particular patient, and by looking at this patient, she knew that the patient did not have GERD reflux, acid reflux. And I said, like, how do you see it? It was really odd. She felt very strongly that she knew this wasn't the case, but you can't really look at people and know. I think we get forced to do that because we have to. It's like, I'm taking care of somebody, I have to look at them. And if they won't tell me, I've got to figure out through my observations what's going on. And sometimes we go a little overboard thinking that we know. And I tend to want to be skeptical and really find out what's going on as best we possibly can. So when you just look at somebody, I'm having a little picture here of one of our family's cockatoos, a Moluccan cockatoo, and she's looking. She looks from both sides, actually. It's very interesting. So looking at GERD, what would you see? So you might see somebody who burps a lot, holds their chest. They might make the first complaint might be of chest pain. Somebody works them up and says their cardiac is okay. They might complain of sore throats, get stomach aches, make themselves vomit. So you get the feeling to come out. So that doing it on purpose for attention, vomiting, I'm always concerned about. And learning from the physicians I work with, we're always concerned about GI issues that are real. Having food come back up after eating, coughing while eating or right after eating, or if they actually have a study that shows dysphagia, I'm concerned, that may be part of what's going on. And then if they have, altered diets, why did the diet get altered? Sometimes we find people end up on a pureed food and we have to trace back to find out how do we get down that road. It's a fairly young person. What's going on? Swallowing problems. Severe enough for a G tube. Have a case like that from Maine. Diagnosis of repeated aspirations by history, problems swallowing, choking, coughing, individual avoiding swallowing foods or eating foods that are difficult to swallow. Individuals been spitting up food, as I said, sores in their mouth. So these are just a list I've generated of things you might see without the person necessarily making an accurate self-report of what's going on. So the first primary care physician with whom I worked on the inpatient unit, Susan Abend, she was fabulous. And she used to use the term round up the usual suspects, because if we couldn't get a self-report that was accurate, we couldn't get enough of the medical records, we couldn't get the story, she'd say, well, we're just going to round up the usual suspects. So what were the most common things that people were suffering from that we had to find out what's going on? So we'd look for constipation, and sometimes we had to do it with that abdominal x-ray, comment on stool content, because even on the physical, you wouldn't really be able to tell that there was some high bowel stool retention, acid reflux, sedation, which I haven't talked about a lot, but I will a little bit more, drug-induced movement problems, infections, dental problems, sleep apnea. There's a lot of that gets missed or just not treated. UTIs, urinary retention, often leads to UTIs. Males, young males don't tend to get UTIs. If that's happening, there's some other pathway we have to explore. Excessive food drive has been a big issue I've been watching lately. So if you want to have the worst intense need to eat and never feel full, you should have the psychiatrist prescribe you Zyprexa with Depakote. So I see all these people, and then we can write a behavior plan because they have this problem with seeking food all the time, and that can make them even more distressed. Dehydration, toxic metabolic states, that's the encephalopathy, the delirium type thing. So one of the questions was, could I talk a little bit about seizures? So somewhere about 30% of people with autism will have a history of epilepsy or seizures. And we frequently see people with epilepsy or seizures. And I think with IDD in general, a little bit more in autism. And a seizure disorder may be present. A seizure disorder is more than a single seizure, however, or acute seizures, because sometimes people have a seizure and there was an acute cause for it, and they had the seizure, and if they don't get exposed to that acute cause again, they don't have recurrent seizures. You know, they have a high fever, it's a toxic drug kind of thing happened, and they had a seizure, and it resolves. And often I would find, or we find in my team, people who are on anti-epilepsy drugs for years, even though they only had one of these acute seizure events. And those are one of the reasons that I nag people to death to get as clear a history as we can get for my neurologist on my team to look back at and see if that's going on, and try to correct that, because we don't want to expose people to all those medicines and their side effects if they don't need it, you know, if it's not there for a purpose. There are many seizure subtypes, and I think a critical thing that happens in the care of our folks with challenging behavior and mood issues and seizures is that we have a hard time characterizing the events that get counted as seizures or understanding what it is that we're seeing. So people can have the big seizures, we used to call them grand mal seizures, generalized tonic-clonic seizures. They can have absence seizures, most people know, without a brief loss of consciousness, but it's easy to miss those because you can see people staring off, and it could be for many different reasons. Myoclonus is a sporadic kind of jerky movement, clonic, repetitive jerky movements, tonic, muscle stiffness, and atonic, loss of muscle tone. So some people have those drop seizures, atonic seizures. They just go down really hard. But most of us understand what the grand mal generalized tonic-clonic seizure looks like, but some of the others are subtle. And if I had more time, I could show some video clips so we kind of understand what they look like. Some of you have a lot of experience already and know. But in terms of seizures and challenging behaviors, the most common association between your seizure disorder, seizures, and challenging behavior or aggressive behavior is really what we call postictal, after the seizure. When people have a seizure, it's just extraordinarily rare that the seizure itself is an aggression. Seizures tend to cause a disarray in your brain, and you can't even be that kind of organized. So it's generally that the seizure doesn't equal aggressive behavior, but sometimes before and sometimes right after, you will see aggressive behavior because people may have issues that associate with the before and after periods with seizures. After seizures, you're confused. Somebody tries to help you, you might hit them. They're not common, but for some people, there are auras that cause enough anxiety that they might get agitated before a seizure. And there are people who have seizures where they actually have a big seizure and actually kind of emotionally and behaviorally calm down for a period of time. And working up to the next time when they're going to have a seizure, they get more grumpy and agitated and even aggressive. And they have a big seizure, then they calm down again. It's not that common, but we've treated people with that kind of thing in the past. If a person's not seizure-free in a good dosage of a single anti-epilepsy drug, AED, then adding a second one, according to the research and my doctor friends have taught me, only gets them seizure-free 10% of the time more. I mean, that it only adds up, that way. And though the second drug may help, but it's not usually going to cause complete control, usually adding that second one. And 2 drugs have more side effects. So when I see people on 4 anti-epilepsy drugs and have a VNS implanted, that's a gizmo that goes into you that you use to control seizures. For another day, we can talk more about seizure disorders. But in any case, there may be some concerns that we've gone too far and we're not really gaining as much control. And I've actually, one neurologist I work with said that he's seen the case where too much anti-epilepsy drug was probably why the person was still having some of the seizures they were having, because it was causing side effects. So seizure imitators, the things that, I would look for, fainting or syncope, mini strokes or TIAs, low blood sugar. So some of the people, I didn't fix that error there. Some of the people who are treated for diabetes, we get really worried about them having high blood sugars, but the scary thing can happen is their blood sugar gets too low, and that can be associated with seizures and can actually look like a seizure when it isn't a seizure. And it's a kind of scary problem because you can get very, very ill from that. Sleep disorders such as narcolepsy. I had migraine with confusion. Movement disorders, the ones that we see a lot, where people are not sure if this is a seizure or not. Even the experts have trouble figuring this out. And that's why it's really cool if you actually have video of the smaller seizures that you're not sure if it's a seizure or not. Movement disorders like tics sometimes look seizure-like, the eye blinking kind of thing. Tremors from side effects from medication, or dystonic things that are side effects from antipsychotic medications, what we call extrapyramidal symptoms, can sometimes be imitators. And people think someone's having a seizure, but they're really having these other events. So we need to do a differential and figure that out. So we can have fluctuating problems with body metabolism, panic attacks, and then there are things called non-epileptic or psychogenic seizures. And I just had a case where people said, don't worry about this guy. He has lots of psychogenic seizures. He's nearly dead from his seizure disorder. You got to be careful about what you say isn't a real seizure. We're not worried. And psychogenic seizures are generally exhibited by people who do have epilepsy. And unless you're a super expert, you want to be really careful about saying, well, we've decided that isn't a real seizure. So I love Alice in Wonderland and Through the Looking Glass, and I kind of used her to do trainings with people about some of the worries my team has found about, polypharmacy. So one pill makes you larger, one pill makes you small, but the ones your doctor gives you might cause side effects. And so in the population of people with IDD, again, I worry because I don't know. I think sometimes they don't report exactly how they're feeling when there's a side effect, but there may be things we observe. And it may be, if you don't comply with your medicines, the first thing someone says, oh, he's non-compliant. We must write a plan to make sure he takes his medicines. My first thought is, if he's non-compliant, maybe he doesn't feel well from the medicine. We should find out if it makes him feel crummy, because that's a real thing. It's only happened to me. I can remember taking an anti-hypertension drug that made me feel really lousy. And then I got a different one from my doctor because I could identify that and ask for some help. So it's really important. So people with IDD are really, really, really treated with a lot of drugs. And I was just on a meeting this morning with some people from London. I'm working with them on a book chapter about people with IDD, with bipolar disorder. And we were talking about this. And in London, they have a program called STOMP. And it was generated by people with intellectual disabilities and autism, and other people have joined, professionals as well, and it stands for Stop Over Medicating People with ID. They call it learning disabilities in the UK. But there's a lot of concern, about just, pill after pill after pill after pill being given to people with IDD. And they have side effects, and they have, there are problems. So in this particular study, and it's an old one, so the rates are even higher in the US. I think they've gone down a little in the UK. I don't think we give it the attention that other people give it in other parts of the world. But in this case, 64% of these kids with autism spectrum disorder had at least one psychotropic med, and 35% had evidence of psychotropic polypharmacy. And I can go on and on about this, but just a lot of overuse of psychotropic meds, where I think sometimes the problem can't be fixed with just adding psychotropic drugs. I often found that the antipsychotic drugs with the kids with autism can slow things down for a period of time, but as a long-term treatment, I have doubts about it because most of those kids end up on yet more drugs. So there's higher doses of one antipsychotic, a different antipsychotic, adding a mood stabilizer, adding other kinds of medicines. So in the UK, they have a guiding system for best practice with for people with all sorts of things, but for people with IDD, they're very clear about that the use of the antipsychotics, they feel strongly that the evidence is only really there for using it in people with autism short term, not as a long-term solution, and not without other modalities of intervention in particular. So one of the things that I've learned is that people with IDD and with autism spectrum disorder, they frequently, the kids, the younger they are, the more frequent it is, but a lot of folks get diagnosed with attention deficit hyperactivity disorder. But what they found is that a lot of the people with IDD don't respond. They look like they have ADHD, but then they don't respond to the medicine the same way, and they're more likely to have side effects. And I think one of the things that this is probably related to is the appearance of I have ADHD, maybe the surface again, but there may be different pathways. And in my work on the inpatient unit and in other places, young people with ADHD, the anti-ADHD medicines are remarkably fast at working when you're on the right path, and they're going to work well. And so I again see people with IDD on these drugs not really being very helpful, but they stay on them. They keep getting on more of them. So one of the things that I and my physician team members work hard to emphasize to people is try to recognize when the issues are not drug responsive. Not everything can be fixed with a pill. And so a lot of these people that we're seeing who aren't like doing really well, they're still having a lot of difficulty. They have histories of trauma and hardly ever get diagnosed with PTSD. And they have drug side effects from their antipsychotics that aren't really, doing a lot for them, but they still remain on these medicines. So this little picture of the girl looking up, she has a thing called ocular gyrate crisis, and that's a side effect of antipsychotic drugs. It's a dystonic event, so the muscles are behaving in an odd way. And one of my most astounding cases was a young lady, kind of transition age woman with autism on the inpatient unit, and the chief complaint was about, her not talking much anymore, pacing around. She had been doing well in her school program. Those guys go to school till they're 22. And she was having a really bad time. but I think part of it was a new system at school. But in any case, they said she's always staring at the ceiling. Why is she always staring at the ceiling? And lo and behold, we went, whoa, we saw the staring at the ceiling. We ran and got her an acute medication for the staring at the ceiling thing. And her eyes came down, she relaxed, and she hadn't been speaking. She walked down the hallway and asked us for more of that medicine because she felt good for the first time in quite a while. So she was a person who had been treated as if her issues were because she had autism, because she had issues. She ended up on an antipsychotic, and it caused her this terrible side effect. And she was much relieved when we recognized this. And she actually responded much better to treatment for anxiety. She had anxiety, and both medical and non-medical interventions for anxiety. I know I've got some folks out there who understand how to use positive behavioral support treatments for anxiety, use sensory modulation things, other kinds of interventions. And this gal did very well with those. And I think she did also get some medicine for her anxiety and SSRI. Anyhow, so these are 50 of our multidisciplinary evaluation cases. And the percentage for a variety of medical issues that we felt pretty strongly were going on. Some of them were recognized. Some of them we may be the ones who said, we really think this is happening. But what we saw was that a lot of them have constipation. Some of them had reasonable treatment for the constipation that recurred now and again. And some of them didn't. Many with reflux, past occurrence seizures, 42%. That's high, and probably because we're dealing with people with more challenges. A third of them had obesity as an issue. A real lot of them had hypothyroidism. That's a really high rate for your thyroid being off. 30% had these antipsychotic drug side effects. And then as many as 12% had swallowing problems that we're pretty sure were due to the antipsychotics. And that's pretty important. And other forms of dystonia. So the drug side effects they're pretty important, and they're there, and people need to think about those. And many other issues. And it's really, really important, again, I think, to be sure that we're not trying to give more of the medicine that causes the EPS. We're actually giving more of the medicine that causes it because it causes the person to be moody and irritable and aggressive. So we want to be really cautious about that. So Alice, said that, she generally gave herself very good advice, though she very seldom followed it. So I think there's some good best practice guidelines out there, but do we really follow our own advice? Not so much. I mean, I don't think there's a lot of, if you look at anything that you would call a best practice guideline, it doesn't say what you really need to do is get this person on 4 or 5 or 6 psychotropics and they'll be all set. That's really not, what people recommend. And if you're actually interested in this, I would Google and look up what are called the NICE guidelines, capital NICE. Help me, I don't remember exactly what it stands for, but it's the National Institute, blah, blah. But in any case, they have some great guidelines for people with IDD and their treatment. So what do we learn from RCTs? That's randomized controlled trials. That's how we decide in the research world that we're really confident that a medicine worked. So you'd have, for example, if you were studying depression, you'd have a group of people with depression and then divided in half, similar groups of people with hypertension, and then you would placebo control it. So some people would get a placebo and some people would get the antihypertensive drug, and then nobody would know who got what, and then we could tell if it really worked. So that could be very, very problem. So I just got a flashy message. Are we doing okay, Brooke?
We're all set. She just added the guidelines.
Okay, goody goody. I'm sorry, I thought it was something.
Don't worry. We have 25 more minutes. Don't worry about it.
Cool, thanks. So these randomized controlled trials are like the gold standard for assessing whether medicine works. But you have to be a really good consumer of the research because some of it's a little tricky. Most of these are very brief. and so we get the impression that, we've had a really good study of these medicines, and they do get FDA approvals, but then later down the road, we learn a lot more about them. So prescriptions of potentially inappropriate meds to older people with IDD is a big worry too. I actually didn't cite it here, but I helped work on a paper about treatment of people, older people with IDD. And it's a big concern because the side effects are even more scary for people who are older, and you have to be very, very careful about this. So something I would pay attention to in the people that you're trying to support. And these researchers concluded, some of it was important to me, although prescription of potentially inappropriate medications overall is more common among people with ID than in the general population, the opposite pattern is found for medications for pain management. So what they really found is that it was rare when somebody got upset that people said, well, maybe this person just really doesn't feel well. Can we offer some Tylenol or ibuprofen or something like that before we go to giving them an extra bunch of Haldol or Risperdal or whatever else? And they really looked at this carefully, and they were like, wow, there's a whole bunch of these people where if it was you or I, we definitely start with something for pain management. So I used to be a smoker. I love to smoke. It's a very terrible, awful thing, and I haven't smoked for many years. But in any case, it was a stress reducer, and you see it in a lot of people with chronic mental illness smoke. But in any case, stress affects us in all sorts of ways, but it actually worsens, can cause and worsen movement disorders. So it's something I think about too when people have these drug-induced movement disorders. When they're getting emotionally stressed, it exacerbates them. So some people think it's like he turns it on and off. It's not always there, but sometimes you see what we call waxing and waning. Sometimes the problem is greater than other times. And that's natural. It doesn't mean it isn't happening for a reason. So put yourself in the other person's shoes feelingly. This is another one of the House of God laws. When you find someone who shows empathy, you follow, watch, and you learn. And so for me, one of the most important things to helping people is trying to find somebody, in the family or in the caregiver system or somewhere there who really, really is trying to relate to this individual on, a feeling level. And again, it sounds kind of trite, but it is actually how we can learn even about these medical concerns that I'm focused on today. The neurologist that I worked with, who was wonderful, there are always kind of issues about she spent too much time with the patients, and she'd run over, and you always had to wait for the appointment, but it was worth waiting. She really, really cared and got to know these individuals. And she said to me, it's not just I'm a nice person, I'm just getting, it was partly that, but part of it was, really that she said, I really learned more about what the symptoms are by learning like what this person's life is like, how, other kinds of things, just general kind of conversations. And I learned so much about, she was a Parkinson's specialist. She treated a lot of people with Parkinson's disorder and other kind of unusual disorders. But I think it was just an important quote. I really liked it. So anyhow, recent case, misdiagnosed with bipolar disorder, which seems to be a misdiagnosis that happens very frequently. I actually have a training about how to not mistake this and think it's bipolar disorder. And this person treated with antipsychotics, anti-epilepsy drugs, and lithium, and takes other drugs for side effects of the drugs that cause constipation, develops a bowel obstruction, then this was one not the two most recent ones I was talking about, develops a serious lithium toxicity, and then gets diabetes insipidus, which is different from regular diabetes. It means your renal function, your kidneys aren't working, and on and on. He nearly died multiple times. He's still at risk. It all started with the wrong psychiatric diagnosis, because when studying his history carefully, he didn't really meet criteria for a bipolar disorder. He didn't have, the history consistent with that. He just had periods of sleep difficulty and agitation and aggression, and he looked grumpy and he paced a lot. But that didn't mean he had bipolar disorder. That could be many, many different things. So sometimes the drug side effect thing and the over-medicating starts with not getting the accurate initial psychiatric diagnosis. So the majority of patients in each group in this study discontinued their assigned treatment owing to inefficacy. It didn't work, not being efficient or efficacious rather, and or it could be from intolerable side effects or other reasons. But this is a very famous study where they called it a real-world study. They're referred to as the CATIE studies. If you talk to any kind of, psychiatrist who's been around for a few years, they'll know the CATIE studies. And they called it real world because they looked at people with schizophrenia in multiple sites. And the outcome in the study was that you wanted to stay on the medication. The doctor and you together decided this medicine's helping me feel better. And even if there are some side effects or issues, it's worth it. We did a risk benefit. I'm going to stay on this medicine. And it's a very famous study. And to me, the most profound thing is that 74% of people didn't want to take any medicine, any one of the antipsychotics. They're not fun things to take. So it's just something to keep in mind. And our folks, if they don't take the drugs we give them, they're non-compliant. So the other thing the CATIE studies showed is there wasn't really a lot of difference in the efficacy or the stopping the meds for side effects. There wasn't really a great big difference between the old antipsychotics and the new ones. And so I think that may be part of what kicked off some resurgence of using things like Haldol and Thorazine. At least I'm seeing it more than I expected to at this point. And I have some interesting info about the newer antipsychotics. So anyhow, unless these drugs really help your psychotic symptoms a great deal, as the CATIE study showed us, that you're probably not going to take them. So in Europe, they did a faux kind of or follow-up kind of looks like the CATIE studies with people with IDD. And so they looked at people with IDD who were they weren't clearly psychotic. They're mainly taking antipsychotics for aggressive behavior. And they did a multi-site study, and they looked at what worked, and had the placebo. Some people got a placebo, and nobody knew who, and some people got regular antipsychotic drugs. And I thought it was fascinating because the placebo was the most effective treatment for the adults treated with antipsychotics for their aggression. And they had Risperdal and Haldol and placebo. And the best thing was placebo. So I think it gave us a little bit of a lesson. I think we talk ourselves into the fact that these drugs are doing more than they're doing. And what they are doing in many cases is slowing people down. And then that stops after a while. So most critical, individual profile of each of these drugs has a different impact on various neurotransmitter systems. I've been taught by my brilliant colleagues, so, it's really about individual drugs. So we talk about the typicals and the atypicals and the first generation and the second generation. And a lot of the really smart doctors say that isn't even like a smart way to break it down. It really is each one of these drugs affect neurotransmitter systems in the brain differently, and each one has a slightly different profile, and that's how it's best to understand them. And again, a recent study that by actually some of the colleagues from London, Sheehan et al. In particular, there's another study by Brophy et al., but they found that these extrapyramidal Parkinsonian symptoms occurred much more often in people with ID than in a neurotypical comparison group. And in fact, they found that a deadly antipsychotic, although rare, side effect called neuroleptic malignant syndrome occurred much more often. I think it was like 3 times more often in the people with ID. And when I ran my inpatient unit at UMass, I remember talking with the team, like, why do we have as many people with NMS as we do compared to the unit next door to us? That was just one of your generic units, didn't specifically serve any particular type of disability patient. And they didn't have NMS as often as we did. It was kind of like mysterious. And now actually the research shows, and it kind of makes sense. So people who have neurotypical brain and they already have often neuromotor problems in their brain, well, of course, they're going to have more of these neuromotor drug side effects. They would be more at risk for them. And it kind of makes sense. But again, it's something I try to teach and throw out there because I think we sometimes use as our reference group the research that says, oh, this drug is less difficult for people, but the people in that study didn't have intellectual and developmental disabilities. If you use that reference group, you're going to make mistakes and you're going to underestimate, the problematic outcomes from using some of these medicines for people with ID. And again, like if they're super effective, low profile of distress or discomfort, cool. But I don't see those people. I see people where it's not working that well. So newer antipsychotic drugs, they all said they're not going to have the tardive dyskinesia and the shakes and the tremors and the akathisia. I think, does everyone know what akathisia is? So akathisia is like you had restless leg syndrome all over. So you feel like you can't stop moving. It makes you feel really crummy. Makes people super distressed, causes anxiety. I've seen case after case of people with ID, and we pretty well showed they had akathisia, but they were brought to us and we were told they were manic because they were pacing around a lot. They're manic. And in turn, on the surface, it can look very similar. In any case, in contrast to previous studies using Haldol as a representative, first generation older drug, there were no significant differences in the Katie trial between one of the old ones and one of the new ones, to sort of make it simple, in terms of Parkinsonism. So I think they weren't really telling the truth. I think it was the way the studies got done. I'm biased maybe, but I really don't think for people with atypical brains in particular, that you can count on these newer medicines aren't going to have those side effects so much. They're going to have other side effects. Well, they do, because they cause people to get overweight and people develop diabetes. And then I've seen studies say that, oh no, it's not due to the medicine. It's definitely aggravated by the medicine for sure. And it's fine if you take medicine and it works wonderfully and you feel better and it targets the things that we hoped it would, and your life's better, then you should take the medicine. My complaint is so many people with IDD and autism spectrum disorder, we hadn't made their lives much better. They're not doing great. So it's an issue that I feel worried about. So I had two older brothers, and me to my brother, you remember how you never found me when we played hide and seek? And my brother said back, did you know that we never looked? True story. No, they were pretty happy when I hid. They didn't seek me. And I don't think that in general, we look for these motor side effects of the medicines. I've seen so many people. I wish I had Dr. Ravin here, the movement disorder specialist neurologist. We had patients where they had an AIMS study. Some of you know what that is, and it's looking for drug side effects from the antipsychotics. And you're supposed to do the AIMS and make sure the person doesn't have the side effects. And they would have no side effects in their AIMS, and they would walk into our clinic, and the neurologist would say, "What? How did you conclude that?" It's very unclear. So in any case, it's still a worry. And I often torture my daughter by using her pictures because I only have one kid. And this was Nicole in high school. She used to stay up really late. She didn't like to get up early in the morning. I don't know if people know anybody like that in their family. She was so well behaved in this picture. And then I would tell people, then I woke her up for school. And then it was really, really bad. Well, we had patients sent to our unit who kind of looked like that. And people said, they haven't been having a lot of challenging behaviors recently. I know they haven't had a lot of consciousness recently either. And that's an extreme, but we see it. I also saw people who were very sedated and slowed down and still trying to hit me. and still trying to be aggressive and still looking kind of miserable. So it's really important to recognize, when we accidentally, inadvertently kind of are happy that we're using some sedation because somebody's been so out of control. We used it on the inpatient unit short term, so we could just get things calmed down, safe enough to figure out, is this person got any medical things that got missed? Is this person got this or that kind of thing going on? So it's not like nobody should ever do it. But drugs prescribed, for psychiatric reasons and psychiatric drug side effects, can also be associated with things called a thing called hyponatremia, which is low sodium, and that's a thing that can be dangerous too. Like, if you have very low sodium, you can be very, very sick, and many of these drugs are associated with that side effect. And if you have low sodium or hyponatremia, it can cause you to have, going down hierarchically, some really serious problems, but it can be some milder problems, like you can feel kind of nauseous, headachy, you can get confused off and on, loss of energy, restlessness. A lot of those symptoms get misinterpreted as being an acute psychiatric issue. And there was pretty high rates of low sodium, not always symptomatically, but low sodium in the population that we served on the inpatient unit. I've also given you this little slide in the handout that gives you, like, here's some things that you're more likely to see if somebody has delirium. Here are some things you're more likely to see if somebody has dementia, just to sort of help people make that. Remember, I said, like, don't want to jump to the dementia conclusion. It's a way down the road conclusion. We want to start out making sure that somebody doesn't have something we can fix. So abrupt onset is more common in delirium, and kind of an insidious slow onset is more common in dementia. And the duration, in delirium, it can be prolonged, but it's usually a shorter term event. And like I said, the effects are very prolonged in people who already have brain impairment, more so than in the general population. But you have a dementia, and it goes on, literally for years. There's differences in terms of attention. So I sat with this guy where he would have a conversation with you and literally fall asleep in the middle of it. So we talk about that waxing and waning sensorium. So he's chatting with me, and then he gets a little slow in the way he's speaking. Then he's like literally asleep. Wake up, talk to me some more. So it's that level of arousal alertness is more common in a delirium type of state, where just not being able to focus your attention might happen in dementia. So you'd have that sort of fluctuation. And then these other kind of features that are listed here, I just hope it's a little bit of a helpful tool when you're thinking about why is somebody's way of, behaving changed so significantly around, these domains. So congenital movement disorders are a risk factor for drug-induced movement disorders. So the other thing I learned is if you have cerebral palsy, or you have a hemiplegia, you have other types of very history of traumatic brain injury, you're going to be at elevated risk for the drug-induced movement disorders, which I have mentioned, but I didn't mention a lot about this. You see people who have swallowing problems and dysphagia and even need tubes placed and have gait problems and all those kinds of things. It's more of a risk issue if you have really observable challenges to your movements baseline, congenitally for many years. So in this particular research, I began to get really interested in when somebody's on antipsychotics, and we can pretty well conclude they didn't do the job, and they've had multiple antipsychotic trials or whatever, they've been on them for years, and this, we got a good reason to say it's just not working. So this particular wonderful researcher, Dutch researcher, whose name I'm not going to be able to pronounce, but anyways, she, I actually saw her speak at a conference in Europe, and pretty amazing work that they're doing there, and they're still doing more work. So it's in your slide if you want to Google her, or Google Scholar her name and find what she's been writing. But in any case, they found that if you look at people who had intellectual disability and had long-term antipsychotic treatments, that health problems included, like half of them, if the long-term group had extrapyramidal symptoms and half of them are overweight. So use of atypical antipsychotics did correlate with elevated glucose and elevated blood pressure. They had 99 individuals with ID who had used antipsychotics for more than 1 year for behavioral symptoms, and higher age and more severe ID was correlated with dyskinesias, with those, like most of you have heard of tardive dyskinesia, a form of dystonic event. Higher dosage of antipsychotics did correlate with Parkinsonism. So, that kind of stuff that makes sense to us. This is them. I want to make sure you had this study, the full quotation, if you want to look it up. It's what I think a very important study by my colleagues from London, showing that movement side effects of antipsychotic drugs in adults with ID were greater than those without ID. And anyhow, more and more research is happening, but still not a lot, and not so much of it in the United States. I have to often look at the Bretts and others to find more concerns, like I said, about, are we studying how these movement disorders happen? And, are people paying attention? In this study, they were just talking about going through records and reviewing them and saying, why aren't people writing about this? Why aren't they looking for this? People should be more concerned about this. And this researcher that I just mentioned concluded that clinicians who prescribe antipsychotics to individuals with intellectual disability should carefully balance the potential of benefits of prolonged treatment against the risk of health hazards. She's really worried about that. And like I said, in Europe, they're worried more so about polypharmacy and overuse of medications. But one of the best reasons I brought up her name is she's one of the people, and there's some other people who've looked at what happens if you had the antipsychotic. It didn't really work that well, and then you go to discontinue it, and lo and behold, the person goes to pieces. They look horrible. They're having a terrible time. And what's been discovered is that you can't stop them quickly. You have to go slowly, and you have to have other things that you're going to do, even if there's a little bit of an uptick related to the discontinuation, not to the drug was working, but to how you discontinued it. That's what you got to be ready to deal with, so the person can get through coming down off the medication. And that, this is a frequently missed phenomenon. I'd heard people say, well, they always have to stay on the Haldol, or they can never be without, their Abilify. And really it was that when somebody tried to take it away before, it was done just too rapidly, even in ways that doctors feel like, oh, well, we spent 4 weeks tapering it. And we spend much longer tapering the drugs, particularly in people who've had long-term exposure. And the other thing is that if you have a movement problem on the medicine, if you have a side effect on the medicine, it might even get 4 times worse when you discontinue it, that same medicine. So you can see one of the things we used to see on our unit is people would have worse movement symptoms, more EPS. They'd get really restless, they couldn't sleep, and they'd have poor PO intake. And that would, they didn't eat well. And these things would be evidence of a discontinuation syndrome. So some of these studies found that that a lot of people were returned to baseline when they took the drugs away. And they actually also showed, we saw this all the time, people didn't just look, we didn't just eliminate some of the problems on the medicine that the person had. People really perked up and looked happier and better. And I think a lot of people don't realize, one thing that can happen if I get rid of the antipsychotic is people could look worse and have a resurgence of their problems. The other thing that can happen is people can look a lot better, especially when the medicine really didn't seem to be working, if we're careful about how we taper it and people are ready to do it. So predictors of success were mainly, I was shocked. Some of it's about the medicine, how long you've taken, how much you took, but a lot of it was mainly in staff and environmental characteristics. So if staff were very, very, very anxious about taking away the antipsychotic, even though it didn't maybe seem like it worked really that much, people would do poorly. And this was astounding. A lot of people are very surprised by this, that a lot of the, influence on positive or negative outcome isn't in the patient or even in the dosing of the medicine for the patient. So there are studies that show there's placebo by proxy. So if I'm a parent and my kid's in this study, I think they're going to get better, they get better. There's huge placebo effects in autism research. And I call this reverse placebo by proxy. One more of my impossible things that I've learned is that I think if people expect the worst will happen. And I actually, if anybody wants it, I have a whole outline of what I think you should do if you're thinking about this, so that you're really, really ready to taper and get rid of an unhelpful antipsychotic medication. And if somebody has, like I said, the chance, I would look up this particular author and some of her work on this. And they did a lot of look at how to taper the drugs. And they did at least a 14-week discontinuation, and that worked. I think it didn't work on the people who had too many drug side effects. And that's when you need a longer tapering period. So anyhow, patient's response to therapy is affected by the behavior of other people who know the patient is undergoing therapy. So it's really, we're all important, and it really does take a village to help people when we're looking at these kinds of things. So as I said, the higher rates of the extrapyramidal symptoms on the medicine make it harder to discontinue it, even if it didn't seem to be helping in the emotional and behavioral domains that we thought it would. So repeating the same actions, expecting different results, I don't think that's a good plan. And I think we keep seeing it in the patients that we see. We just keep saying, well, if Haldol doesn't work, try Thorazine, try Abilify, try Risperdal, try, wait a minute, maybe those things won't work and we have to try some other things. So these are in your handout. I wouldn't even remember if I put them in. So it's a brief version of the steps to tapering psychotropic medications to help you out. I'm not going to go over them one by one, but anyhow, best practice says you want comprehensive multidisciplinary evaluation when people aren't doing well with these kinds of treatments. And we want to use, a developmental biopsychosocial assessment, because I'm a developmental psychologist. I added that developmental piece on, and people shouldn't just get drugs, obviously. We say that, but my goodness, I see a lot of people where that's the main focus, even if they get other forms of care. It's too much on, people want the magic pill. They want the magic pill to fix everything. So I think, again, the research, be smart about how you read the research, because it says the person tolerated the drugs well. Maybe. We're not always sure about how we come to those conclusions. And I think people having multiple psychiatric diagnoses, be sure there isn't diagnostic confusion that's leading down the path to the wrong kind of treatments that leads down to these issues. And some of it is missing the medical things and missing the med side effects, or thinking you have bipolar disorder when you're a traumatized person with anxiety, and that's so much more common, trauma, anxiety. So anyhow, these are the kind of things I think people really need. I talk about all the time. They need to be busy with things that make them happy and feel fulfilled. They need a way to have a positive personal identity. They need really positive behavior supports, not just behavioral interventions, sensory things, speech things. They need a life. So all those things are very, very critical. And then I ask, when doing assessments, I ask the folks to tell me what they see and draw a picture with words, and not just tell me their hypotheses, and then use video if you can. Be cautious, be a cautious consumer of the research. This was an ad I remember seeing, Thorazine, a psycho sedative, study rather, free of side effects. I think we learned that's not true. And I think preventing works best. Very much so. I think preventing works best. And I always vote for prevention when we can. So that last law, learn your trade in the world. Your patient is never only the patient, but the family, the friends, the community, the history, the climate, where the water comes from, and where the garbage goes. So I thought that was kind of fun. Your patient is the world. So thank you. I hope this has been helpful. I kind of raced a little bit through some of it, trying to fit it into the hour and a half. And I gave you a couple of references. I like referring to myself. Sorry. No, I just, and I can give you more. If people need more, let me know. Brooke knows where to find me.
Dr. Charlo,
Yes.
I also put in the chat for everyone that any consults to the Beckett Institute, definitely send it to the appropriate clinical director. So
Yes.
Dr. Racino for the South region, Dr. Lloyd for the West, myself for the North. And I also, Dr. Charlo, provided Microsoft Forms if people have more questions, comments. But why don't we take, if you don't mind, if we can
I don't
take it.
mind staying. I was more worried about these poor people who are working their hearts out.
So
You know?
we can try to
Yeah.
open the floor for at least 10 minutes of questions. I know we already had a question. We're
I missed it because I do that. I can't see
that's
them.
fine.
talking
So
yet.
one of our regional directors in the South region actually asked a great question. He said, is there any more information you can provide about the intersection of type 1 and 2 diabetes with our individuals with ID, autism spectrum disorder, and Prader-Willi syndrome?
Okay, I'm not even sure if I understand that.
If there's any more information you could provide about the intersection of how type 1 and 2 diabetes may impact our individuals with IDD, autism spectrum disorder, and how maybe it can even be misinformed in regards to a behavioral problem.
Absolutely. I think as far as I was thinking more about where can I find a good paper that I could recommend to you that would kind of pull that together for you. But it's a really, smart observation that, and I didn't get into it a lot, but definitely when people have abnormal blood sugars, it affects your mood and behavior. It's so many of these things do. And again, if you're trying to help somebody who doesn't have a really good way to tell you how they're feeling, that's totally going to have an impact. And again, why I get so worried when we don't want to add in unhelpful psychotropics that aggravate our diabetes, because some of these folks, type 1 is a little different. The type 2 is, that's something we're really adding to the struggle by giving people some of these medicines. And if the medicines, like, it's all about risk benefit. If it's really worth it, and my life is better, I feel energetic and happy and good, then yes, take the medicine. If you're still got all the symptoms for which the medicine was described and it's making your diabetes worse, you shouldn't be taking it, and definitely I've seen many people over the years where this affects your mood and behavior, both in my field and in family, people where it makes you feel terrible, when your blood sugars are way off. So it's an excellent point. And I was just trying to think, do I have a good paper? I'll try to look and see if I find a good paper on that.
Absolutely. If you find anything, forward
Yeah.
it to, we'll make sure that everyone has that. Are there any other questions for Dr. Charlo? We try to put a lot of information in only an hour and a half.
I know, crammed it in. So I'm always happy to come back another time down the road if you want to talk about something, drill down on something like, one of the other things that I talk to people a lot about is trying to get the psychiatric diagnosis correct first. Not like I can give you all the answers to that, but I can tell you sort of the red flags for when we saw people. It's like, wow, why did they go down that path? And, that's one of the trainings that I like to do to help people. And, I'm grateful to have been here. It's always good to me. I love it if people want to talk about these things, because I think we can always keep working on trying to make the care better. And it's hard these days. So
I agree. I definitely agree. And
yeah,
as
thank
a
you.
reminder, so if you have any of those complex medical issues, and you think that your person or your individual fits for a referral to the Beckett Institute, definitely let us know, because I think that's going to be helpful for us to move forward. Even though we're not doing it in person, I've had the pleasure of physically going to Massachusetts and being a part of that evaluation process, and it really is phenomenal. But they still pull it together, virtually
Yeah,
for now, but we still run it just the same.
yeah, definitely. And I thank you all so much. Rachel and Brooke are my comrades doing this work. So thank you so much. So And if people, like you said, if people have questions, you know where to find me. I'll try to help them. We can start a little reference library.
Absolutely.
Yeah, I'll send you some things if it
Thank
can help.
Thank you. And it will be posted to the website, so everyone knows. We will post a link to the website for the whole presentation and the resource in terms of the slides. Please definitely use the Microsoft Office forms that I put in the chat. Brooke will also send you yet another one. And then that way you will be able to give any feedback, any questions, and we can reach out to Dr. Charlo and make sure we get it done. Thank you all on a Friday.
On
We
a
had 85
Friday.
people on a Friday, Dr. Charlo. This is awesome.
That's pretty good. I'm
Absolutely.
happy. All right. Thank you all for having me and have a great weekend. I'm sure I'll talk to you soon.
Absolutely. Thank
Take
you
care,
so
guys.
much.
Yep. Bye-bye.
Bye.